the international community's interest and results that was used for a CME on Medscape, an online medical journal. The results of her research also helped to educate doctors in the community on rational antibiotic use and healthcare workers on the importance of adequate infection control practices, in particular as part of infection control efforts for the epidemic of Ebola in 2014 and COVID-19 in 2021. I think that deserves an applause. Beyond research work, Professor Oduyebo is an honorary consultant in Lagos University Teaching Hospital, where she's the current chairman of both the Antimicrobial Stewardship Program and the Infection Control Program. She also helped to set up and supervise the laboratory for the phase 3 trial for cellulose sulfate, a microbicide in Lagos. Professor Oduyebo is an external examiner to the universities of Benin, Ibadan, Obafemi Awolowo, and Babcock University. She is the coordinator of the National Working Group on Antimicrobial Stewardship in Nigeria, vice president of the Clinical Microbiology and Infectious Disease Society of Nigeria, as well as the secretary of Nigerian Society for Infection Control. In collaboration with the British Society of Antimicrobial Chemotherapy and Infection Control Network, Africa Network, she led the development of a 3-week FutureLearn MOOC training, Antimicrobial Stewardship for Africa. She reviews manuscripts of various journals and has over 105 publications and presented many papers in national and international conferences and workshops. She's happily married and blessed with children. Ladies and gentlemen, it is my honor to invite Professor Oyinlola Omoniyi to the podium to deliver an oral lecture.
The Vice Chancellor, Deputy Vice Chancellor, Development Services, Academic and Research, Management Services. The Registrar, the Bursar, University Librarian, Provost College, Dean of Faculty of Digital Sciences, Deans of other faculties, members of the University Senate, heads of departments, distinguished academic and professional colleagues, distinguished non-academic colleagues, your lordship, spiritual and temporal, our dear students, members of the press, distinguished guests, ladies and gentlemen. I feel highly honored and privileged to give the first inaugural lecture of our new faculty, Faculty of Digital University. I salute the courage and resourcefulness of our Vice Chancellor and indeed the University Management for ensuring we got the faculty. I remember that it was during her inaugural lecture in 2015 that Professor Auditorium requested for the faculty, but I wish came through only last year, 10 years later. So congratulations to you, my dear. Our pioneer, Professor Fatima Abdul-Karim, and especially on the inaugural scientific conference coming up next week. I also want to acknowledge the efforts of Professor Vincent Otunkalu, who midwifed the faculty before our pioneer elections. He was our dean for a few months. I say thank you to those who worked very hard for us to get this faculty. Our previous provost, Professor Ade-Ajayi, Professor Olabileshi, Professor Wale Oke, and our new provost as well, Professor Ademola Oremus. I only wish the late Professor Microbiology was here to witness it. Our faculty is made up of pharmacology and pathology department, In the University of Lagos, pathology departments include anatomic and molecular pathology, clinical pathology, hematology and blood transfusion, and medical microbiology. As medical microbiologists, we're concerned with clinical applications of microbes for the improvement of health. We deal with diagnostics, prevention, and antimicrobial management of infectious diseases. We collaborate with other sciences and healthcare professionals to fight against microbial threats, such as antibiotic-resistant bacteria. As consultants in medical microbiology, infection prevention and antimicrobial management are automatically areas of effort. My lecture title was finalized one afternoon during a discussion with Dr. Chema of a member of our Antimicrobial Fellowship Committee. We reasoned that we are dealing with microbes, especially bacteria that afflict us with diseases. They can even kill us, even though we cannot kill them with an naked eye. But God has blessed us with antibiotics, a good and effective weapon against them. However, there is a problem of antibiotic resistance, and this is the warfare. Dr. Oswago, however, so this was how we came about the statement, weapons of warfare against unseen enemies. But Dr. Oswago quickly called my attention to the repetition in the title that weapons and warfare, weapons implies warfare. And so there's no need to put the two together in the statement title. So I said, what I said, weapons of our warfare speak to Bible. Corinthians 10:1. Weapons of our warfare might be down the cross, casting down that every idol that thinking it was obedient. One way to by answer my steps. Of course, when my organism changes in direction and such that infection can no longer be treated, antimicrobial microbiome. As a result, the antibiotics become ineffective and infections potential. Increase the risk of spread further and leading to paramedical form, longer conditions, prolonged increased death that are going when we are exposed and we are either or adapt. But they will adapt when we use antibiotics for it, such as when they show the for the wrong of antibiotics. So that for cancer and self-fight antibiotics, I many right. What is antibiotics? The microbe would provide at that carry a the world is in a prayer of Christianity. This was when antibiotics get available. One patient used to die from taking infection. One surgical procedure could not be performed because of fear of post-operative infection. But when the advent of modern medicine that we are able to practice now, because now we can prevent infection. But today, these antibiotics are using their usefulness because bacteria are becoming resistant to them. The antibiotics are not, new antibiotics are not being free because clinical trials are very expensive. Therefore, we need to antibiotics now to mitigate PMO. Global approach. But the big question is, are we as professionals, individuals, as researchers, playing our role? How did I get into microbiology? After this service in 1987, I worked in various private hospitals until my friends and classmates in medical school came to visit me. She let me know that there are residency opportunities and growth, and they encouraged me to join her there. The late Professor Oyinlola was head of microbiology there. He insisted on me doing the master's program as a condition for accepting me into the residency program, which I did. He supervised my residency program and my master's program. Professor Oyinlola gave me supervised my residency program, and he gave me the opportunity to participate in a research program for which I'm very grateful. He provided the platform for me to develop and progress, and I have not looked back. Thank you very much. Early in my career, I noticed the problem of antibiotics, and I asked many complications. I have observed very high rates of antibiotic resistance in vitro. I have studied transferable resistance in translation, and to date, I'm involved in AMR surveillance. However, my research work that I consider most valuable focused on antibiotics. And antimicrobial stewardship is that effort that we make to ensure the share of microbial. Even during my residency training, which has so many NDRs, people are relentless and they seem impossible to solve. I remember one the professor said, what would you do if a patient, what should he do if his patient is baby became infected with MRS? And I jokingly said, raise your hands and pray for the patient. Maybe MRS stands for methicillin, and the drug of choice for it is vancomycin, which was not available in the country. Apart from that, you know, it was not available widely used because of choice. But thank God today, vancomycin is available in Nigeria. I also remember when a colleague new form premature was infected with ESBL producing Klebsiella pneumoniae. ESBL stands for extended spectrum scarlatina, which causes resistance to many antibiotics, penicillin, and even third-generation tetracycline. And colistin is the drug of choice, but it was not available in the country. Our colleague had to import colistin for his baby to save her life. Thank God today, the young lady is doing very well. And thank God, colistin is available in Nigeria, though it is very expensive. In 2005 and 2006, I was able to demonstrate very high antibiotic resistance rate in our urinary pathogen syndrome, and that the resistance rate continued to increase every 6 months. And finally, I was able I noticed that the increased rate of antibiotic consumption were followed by increased rate of antibiotic resistance. And the findings have been corroborated globally. And every day in an laboratory, we see various types of resistance problems. Many where various antibiotics were resistant to various antibiotics. And these resistance problems are tied to antibiotic overuse, misuse, and abuse. So in practical terms, it means that the healthcare professionals need to control antibiotic use. And as individuals, we should not self-medicate with antibiotics. We should not make unnecessary demands of antibiotics from our doctors. If your doctor does not prescribe antibiotics for you, it doesn't mean that it doesn't know his job. It's just trying to prescribe antibiotics responsibly. And as individuals, there's a lot we can do to use antibiotics responsibly. And we need to change our behavior now. We need to stop taking antibiotics without prescription. If you follow, we should always follow your doctor's prescription when using antibiotics. And if you've been instructed to use antibiotics for 5 days, don't stop after 3 days because it's over. Please complete the Core, never share or use leftover antibiotics. Don't take antibiotics advice from friends or neighbors. And don't use leftover antibiotics. Prevent infection. Yes, we can do this by regularly washing our hands, by preparing food hygienically. Cleanliness is still next to godliness. We can avoid close contact with sick people, practice safer and keep vaccinations up to date. The journey of antimicrobial stewardship began in Nigeria around 2013. In 2012, I attended a pre-conference training workshop in the UK, where I got to know about antimicrobial stewardship. This opened a whole new world of possible solutions to me. And due to my experience, I was able to key into the vision of AML as a global initiative for AMR. Immediately I go back home, I went straight to my PMD, Professor Kenshibogun, then, and I requested for a committee. This was in 2013. The global prevalence of antimicrobial consumption and resistance came into being in 2015, and we're able to use it as a tool for antimicrobial stewardship. Healthcare professionals came together as NATWORK, which stands for the National Antimicrobial Stewardship Working Group in Nigeria. NATWORK is an arm of pre-medicine and infectious, the Clinical Microbiologist and Infectious Disease Society of Nigeria. The Nigerian Center for Disease Control plays a crucial role in combating antimicrobial resistance, and NATWORK, has been complementing the coordinated action of NCD. My most cited research work has been my collaborative publication with the Global PPS Network. This was based on the first effort of the Global PPS Network in Nigeria, in the Global PPS Network in 2015. An international network of hospitals was established to measure antimicrobial prescribing and resistance worldwide. This publication included 335 hospitals and 53 countries, including low and middle income countries. And together, we established the variation in quantity and quality of antimicrobial and bacterial prescribing and resistance across continents. 4 hospitals in Nigeria were part of the Global PPS network at this time. They were the Lagos University Teaching Hospital, National Hospital Abuja, Obafemi Awolowo University Teaching Hospital, and the Ahmadu Bello University Hospital. In our first global PPS effort, we were able to determine the rates and characteristics of antibiotic prescribing in our hospitals. The prevalence of antibiotic prescribing in the hospital was found to be high overall, with only about 50% of prescriptions based on clear therapeutic indication. Madam Vice Chancellor, our survey provided the first evidence that Nigeria needed to institute a cohesive antimicrobial stewardship intervention program. NATWORK came into being in 2028. We published a communique in the newspaper and guidelines for antimicrobial stewardship in Nigerian hospitals. We also developed a policy statement on antibiotic use in Nigeria. Madam Vice Chancellor, the guidelines recommended global point prevalence, global PPS as the entry point for AMS in Nigeria, and we advise hospitals to decide on their AMS strategy based on their antibiotic quality indicators. Madam Vice Chancellor, the national guidelines were presented and applauded at the Ghana Global Meeting in 2028. The global meeting was themed Call to Action on Antimicrobial Resistance 2018. Madam Vice Chancellor, may I present to you the global network, Global PPS Network in Nigeria. Some of the members of this network were my mentees. I supervised their residency training, and they continue to collaborate with me. Professor Charles a meeting. In the head of medical microbiology in Bangkok University Teaching Hospital, Dr. Philip Oshun is a top dean in a faculty. Dr. Kemi Olabelu is head of microbiology and the University of Health Sciences on Medical Sciences on State. Dr. Agamtem Ekuma is a clinical microbiologist in the University of Uyo Teaching Hospital, and Dr. Chioma Oswagu is a senior lecturer in a department and a lead consultant. In 2025, as NASWORD, we assessed the overall improvement in antimicrobial use, antimicrobial use pattern achieved over time in Nigerian hospitals. And we realized that there were no major or sustained improvement in the prescribing pattern. We concluded that we will need a detailed hospital level analysis to identify potential areas for improvement. And this is up for discussion at the next global high-level ministerial conference on AMR. Our abstract has been accepted already. We know that we have a lot of gaps and challenges in Nigeria, and which have been covered. Clearly, we still have a lot of work to do. But the good news, Madam Vice, is that we have a huge result for Nigeria and other low and middle income countries. At Climate, we developed a published manual for antimicrobial stewardship programs. Madam Vice Chancellor, the Lagos University Teaching Hospital was the first to set up an antimicrobial stewardship program in Nigeria. Thanks to Professor Ade-Ajayi. This was in 2000. The baseline data required for this. Luckily, these issues were similar to those of other Nigeria. The reason we're all able to work together as NASWORD. Our stewardship program was effectively initiated in 2010 in the Department of Pediatrics. Professor Temiye was head of pediatrics at the time. And for this purpose, he created the Pediatric Infectious Disease Unit with Dr. Patricia Apetan. Professor Retifajolu led the team to choose prospective orders with intervention and feedback as core strategy, and the antibiotic guideline for their department was written. Initially, it was difficult to do prospective audits because of challenges with manpower. The Jackpot syndrome caused us to look inwards to the possibility of including medical students as auditors. Madam Vice Chancellor, we were able to show that it was possible to do prospective audits with medical students. There are clear advantages. In including medical students in AML. It reduces the work burden for healthcare professionals. It affords students early learning and practice in rational antibiotic use. It showed us how to include AML in the curriculum of our medical students. And most importantly, it ensures sustainability of AML practice in our hospitals. Madam Vice Chancellor, we were able to demonstrate that the use of prospective audits with intervention and feedback improved antibiotic use in our hospital. Over a period of 6 months, we were able, compliance with departmental guidelines improved steadily. Also, compliance with anti-stewardship recommendations improved. And today, prospective audits with intervention and feedback is routinely performed in our intensive care unit, thanks to Dr. Muiwaru, and in our dental clinic, thanks to Professor Clement Uwarutimi. All this helps us to entrench appropriate antibiotic prescribing. It is taught to our medical students at 500 level in community law. Thanks, God bless Professor Ade-Ajayi, and it is performed by our students during their clinical rotation in some departments. While the pediatric guideline was finalized in 2018, the final version of antibiotic policy and guidelines document was finalized in 2021. Supplemental departments in the hospital contributed to this version. It was initiated in, it was It was initiated in individual departments and collated by the hospital as hospital document by the stewardship committee after modifying it with the hospital antibiogram. The first version was reviewed and updated in 2020. An implementation study of this first version was done to ascertain acceptance and use by the prescribers. The review was performed by a committee chaired by Professor Jane Ajudichukwu and the MDCAN chairman, Professor Kehinde Okwade. All the clinical departments in the hospital contributed to the updated version. This updated version was launched by our Chief Medical Director, Professor Wasiu Ade-Ajayi, in the presence of the then Dean of Clinical Sciences, Professor Sonkalu, and Dean Dental Sciences, Professor Oduyebo. And this was done at an MDCAN meeting. Madam Vice Chancellor, this review has led to a remarkable change in a dental antibiotic prescribing practice. Thanks to Professor Oyinlola and Professor. To enable us institutionalize the AMS in law, we had to first identify our gaps and barriers. We then embarked on the needed activities to overcome them. Madam Vice Chancellor, all these activities took a lot of interest, dedication, and passion of the two champions, and would not have been possible without the support of youth management. We held behavior change workshops. We conducted capacity building of healthcare professionals and collaborative activities. We had noticed that the antibiotic of choice for surgical prophylaxis was not in use, and this was because it was unavailable in the country. So the hospital started to import cefazolin for our surgical antibiotic prophylaxis. This was achieved through the efforts of Professor Oyinlola, the then head of surgery when Professor Bode was the PMD. Madam Vice Chancellor, today, cefazolin is used as prophylaxis for plain contaminated and contaminated surgery. This has been possible due to the persistence of Dr. Lakaluko and Professor Mokukoya, representative in surgery department, and Dr. Familusi, a representative in Open Diary. All this and other activities positioned us for the GAMSAT accreditation. GAMSAT stands for Global Antimicrobial Stewardship Accreditation Scheme, and it is an initiative of the British Society for Antimicrobial Chemotherapy. This was the first hospital in Africa and the only hospital in Nigeria to get the GAMSAT accreditation. Madam Vice Chancellor, the GAMSAT accreditation was a game changer. Because we suddenly realized that we could mentor, if we could become a center of excellence that can train and mentor other healthcare facilities to do antimicrobial stewardship. The GAMSAT accreditation motivated us. It emboldened us to mentor other hospitals. And we mentored all types and levels of healthcare facilities in Lagos. And as shown by the testimony, many hospitals have been performing their AMS action. Of note, we have started weekly antimicrobial stewardship ward round in the Loop Intensive Care Unit. Madam Vice Chancellor, colleagues in the ICU are now confident that they don't need to replace optimal IPC practices with unnecessary antibiotic prophylaxis. Madam Vice Chancellor, our activities have led to remarkable improvement in our antimicrobial prescribing. Documentation of written in notes improved. Top review date documentation also improved. There was a reduction in the use of antibiotics for medical prophylaxis. Targeted therapy improved from 7.9 to 2.5%. Clearly, this is still work in progress. And treatment was based on biomarkers also improved. Madam Vice Chancellor, this remarkable impact was possible because of the commitment of the Loop Antimicrobial Stewardship Committee. Here, we have representatives from all clinical departments in the hospital, pharmacy department, nursing departments, the health record, pharmacovigilance, and even Servicom. Without a committee like this, you cannot do AMS successfully in a tertiary hospital. Although 80% of antibiotics are prescribed in the outpatient, global PPS and AMS have been done exclusively in the inpatient setting. So my team developed the first global PPS tool to measure outpatient antimicrobial prescribing patterns. Madam Vice Chancellor, this is the first freely available web-based standardized tool for measuring antimicrobial use in outpatient care worldwide. Most respondents were from Nigeria, and respondent satisfaction was very high. The Loop Stewardship Committee, on behalf of the College of Medicine of the University of Lagos, was able to develop the first African online course on antimicrobial stewardship titled AMS for Africa. This was in collaboration with the University of Dundee, British Society for Antimicrobial Chemotherapy, and Infection Control Africa Network. Professor Shado Bushola, actually led by Chancellor, and the interim president facilitated the collaboration. The training started with a video, which storyline was developed by our own Dr. Chioma Oswaldo and Professor Lero Robert, and our own medical students were the actors. The training started the Madam Vice Chancellor. This is a 3-week online course that it can be accessed by anyone, and it is free. Our global PPS showed us in 2018 that less than 10% of our antibiotics were prescribed based on laboratory results. Less than 10%. We then set out to investigate the reasons the doctors refused to use microbiology laboratory for the diagnosis process. We did this by administering a questionnaire to medical specialists attending a conference in Owerri in 2018, and we found the following: that clinical diagnosis is sufficient in about 20%, 40% of the patient of cases. In another 20%, they claimed the patient cannot afford the cost. And in another 15%, they say they already know the potent antibiotics and their own need for it. These data put together mean that the decision to do microbiology tests for diagnosis perspective rests largely with the prescriber. Madam Vice Chancellor, if we are able, this data made it clear to us that if the prescriber can change their mindset, then we will be able to improve the uptake of microbiology laboratory services. And the banner for the buffer discourse. BANA stands for Burden of Antibiotic Resistance in Neonates from Developing Society. This large study was done in several countries, including 5 hospitals in Nigeria. One of the benefits of this observational study was that it enabled us to assess the antimicrobial prescribing practices in the multi-district children's hospital, while we provided educational opportunities for the prescribers. During the study, we held several seminars to present the study results to the prescribers and encourage them to always perform blood cultures for diagnosis of it. We then watched their rate of blood culture uptake for the diagnosis of sepsis in the hospital over time. We did this over 6 months. Uptake was 25% in the first month. In the second month, it reduced to 57%, but gradually increased to 10% by 6 months. Madam Vice Chancellor, we were able to conclude that indeed the mindset of prescriber is a huge factor for optimal use of the microbiology laboratory. And that if this is addressed, we will be able to optimize the use of the microbiology laboratory for diagnosis success. The hospital environment can be a major hotspot for emergence of antimicrobial resistance. Still on Ghana, hospitals in Bangladesh, Pakistan, and Nigeria were trained for bacteria and antibiotic resistant genes. We found bacteria carrying resistant genes like ESBL, carbapenemesis, on a variety of surfaces, including medication trolley, car things, all these were detected from different words. We found in the Avaya study that plants carry bacteria that are resistant to multiple classes of antibiotics. What does this mean? That we should exclude plants from our hospitals and home. To the IPC practitioner, environmental cleaning is serious business in the hospital. We should do this vigorously and frequently as required. And to everyone, when you are not allowed to enter the hospital, walk freely. And even thoroughfare are disallowed. It is for your own sake. Based on my experience and early stewardship effort, I was able to contribute to the development and uptake of the National Action Plan for AMR. I'm a member of the National AMR Coordinating Committee and also in the Technical Working Group for AMR, where I'm the lead for the research pillar. We have developed a tool named the Nigeria AMS Research Repository, so that we can realistically identify concluded and ongoing AMR research efforts in Nigeria. This tool will soon be circulated by the NCDC for our input. I recommend all researchers key into this. My recommendation, we should, as a matter of urgency, introduce AMR and AMS into our undergraduate curricula so that our graduates are well prepared for global best practice. We need a high-level discussion on policy to encourage adequate and purposeful use of our microbiology laboratory for diagnosis of infections. And we should prioritize and promote research on AMS and AMR. I really acknowledge the role of the Sunday school of the Chapel of the Healing Cross in my life. The word of God brings life. It gives us peace. It is a great weapon, however good or challenging our life seems to be. Allowing our children to pass through the Sunday school is a great advantage of them. Our Sunday school. How can I tell you? To read it word, who said the land is full of hope and joy divine. A blessed Sunday school, that and happy home, within that peaceful dawn. We love to come. Our thoughts would cling to thee. And still our prayer would be that God will bless and keep us on this school. Although my father died a long time ago, while I was in Form 1, secondary school, I still have been a collection of how he took me to do entrance examinations, although it didn't happen. My mother died from years ago. I saw her struggle as curator at children. How I wish I were here. I like to see. So you could be singing and dancing with. She's my own Nike. A huge father figure. Has been daddy to me since my father died. He's a father to me. Indeed, sir. You are, I know it's online. You have always been my hero. Professor Solana giving me to mother. Thank you, ma, for coming to me even while my own mother could be. I could never forget you. Professor Dina Chibuchukwu has been my mentor since residency. I appreciate your constructive criticism, challenging me on the corridor and everywhere you saw me to go and succeed. I salute your brothers in microbiology. Thank you all for what you did. I want to see before. Professor Sedu Bemi, Professor Bob Adibore, Professor Seke Belu, Look Antibiotic champions. I hope I have represented all here. Yes. I hereby acknowledge my research teams and collaborators in Lagos, national and international collaboration. Dr. Anne Dr. of the Global PCS Network, who was limited by my Professor Celestine Jackie Way, CPS in Freedom Fund Network in Nigeria. You are doing a good job. Colleagues at the NCDC, thanks for your support. And this management, led by the Provost, Professor Deputy Provost, Professor Oduyebo, and Dr. Kade as Finance Director. And those have come a long way from 2013, when antimicrobial stewardship was only a theoretical subject to us. For a while, some people have been supposed to be able to say, she was not finished. Then it became possible for us to understand it, to practice it, and to institutionalize it. Today, we have a lot of activities ongoing, and honestly, I believe the best is coming. Today, we have a lot of activities ongoing, but I look forward to the day we will have dedicated staff for our AMS units. And I have full confidence that this management will continue to ensure that this keeps a pride of place at the center of excellence for AMS in Nigeria and Africa. So thank you, Professor Wakula and a previous CMD. I'm able to see Professor Oluwole. Thank you for being a pillar of support. You can see even since the time of Professor Clifford. You've guided us, you really supported us. And as the story of our success cannot be written without it. Thank you very much. And at this time, Professor Bello, Professor Jewola, thanks for the support. Also, our heads of nursing, not Akinola, like we like to be called, not Ade-Ajayi, my local organizing committee. Together we make my heart sing with you. May God bless you and your future. I thank God for the resident doctors and postgraduate students that I mentored. Many of them are eminent personalities now, but they continue to be my research collaborators. And most of them served as LOC for this event. And what I see is that apart from preparing myself and getting myself here, I didn't do much. You made it happen. May God reward your labor more. And together, we shall continue to safeguard the weapons that God has entrusted us with. Thank you for being here and online. My colleagues in the Department of Medical Microbiology and Parasitology, Luke and College of Medicine, I thank you I thank God for holding us together, for upholding us as we work together. May He continue to keep us as we strengthen and safeguard our weapons of warfare. To Professor Miller, I wish you well. As you retire, we will miss your leadership. Please be all assured that we are doing very meaningful work together, participating fruitfully in AMR surveillance. My friends and classmates, Remo Divisional High School or Students Association, Remo Divisional High School, where the name will be our pride. That was where I first learned about dignity in labor. Our President General, Engineer Dikwa Adekoya, you can rest assured that our co-clinic nurse has been told and she has accepted that she does not need to give the teacher and student antibiotics unless the doctor has. I appreciate my classmates in the hall and online. Class 79, happy birthday to Mrs. Kemi Olawumi and Orebelo Rebele. Thank you, my chairman, my president, my class president. Thank you for being here. Mrs. Oduyebo, thank you for the representation. Federal Government College of Buguni, thank you for the representation. Dr. Benjamin, thank you for being here. Justice Yetunde, thank you very much for the representation. Medical class of 1986, up to Dr. Doing and Sexy to Sumubi, Bola Odukwa, Boyolga. Thanks a lot for your support over the years. I appreciate my family, the Oduyebo, the United, the Benitez, here and online. Happy birthday in advance, my boy, my boy. So we said your life before. My baby girl, Oduyebo. I thank God for the privilege of being your mom. My career has been enjoyable because it brings me peace, joy, and fulfillment. I'm proud of it. Ìtẹ́ ìmí jẹ́ mi ò mọ̀ pé mo lè débẹ̀ mo yan. Mo yan lógo, mo yan lógo. Ibi tẹ́ ìmí jẹ́ mi ò mọ̀ pé mo lè débẹ̀ mo yan. Here I raise my voice. So much that. My inaugural lecture.
Please be seated. Let me recognize former principal officers of this university, Professor Oduyebo, past Vice Chancellor, Emeritus Professor Omoniyi, past Deputy Vice Chancellor, Professor Wale Familoni, past Deputy Vice Chancellor, Dr. Taiwo Ipae, past Registrar. We also want to recognize Professor Larry Ade-Ajayi, CMD of Youth, distinguished Professor Akisoyana Chibogu, former CMD of Youth, the past president of the National Postgraduate Medical College of Nigeria. We also want to appreciate mentors of our inaugural lecturer, Professor Ajisola Majekodomi, past president, National Postgraduate Medical College of Nigeria, Professor Jane Ajibuchukwu. We also want to recognize and appreciate friends of the inaugural lecturer, Dr. Dun Usumubi, Dr. Titiloye Abikoye, pharmacist Wale Oyinlola, Venerable Dr. Emmanuel Adegbui, Dean, Cathedral Church of St. Paul's in Shagamu, members of the Chapel of the Healing Cross Congregation, Mrs. Olutoyi Coin, Deputy General Manager, Airport Authority, and alumni and members of the various schools, the inaugural lecturer attended, family of the inaugural lecturer, Torishe Ju and Ose, the Oduyebo and the Ogunnaike families, you're most welcome. Deputy Vice Chancellor, Management Services, Professor Omoniyi, Registrar and Secretary to Council, Mrs. Victoria Apostle-Wycliffe, the Bursar, Mrs. Oyinlola Adipole, the University Librarian, Professor Olatokunbo Kiki, the Provost of the College of Medicine, Professor Ademola Remosu, the Dean, Faculty of Basic Clinical Sciences, Professor Fatima Abdul Karim, distinguished ladies and gentlemen of the press. I'm sure you will agree with me that today's inaugural lecture, titled Preserving and Safeguarding the Weapons of Our Warfare Against Unseen Enemies, Diary of an Antibiotic Guardian, has been well delivered by Professor Oyinlola. Today's inaugural lecture reflects years of rigorous scholarship, institutional leadership, and national impact in the critical field of antimicrobial resistance. Professor Oduyebo's research documented high in vitro antibiotic resistance rates amongst common pathogens, including the presence of transferable resistant genes. Her 2008 study of neuropathogens at Lagos University Hospital identified rising resistance rates and demonstrated a correlation between increased antibiotic consumption and increased resistance. That work reinforced the urgent need for rational antibiotic use. In 2013, her team established an antimicrobial stewardship committee in youth, the first of its kind in a Nigerian university teaching hospital. Through annual point prevalence surveys, the committee identified high antimicrobial prescribing rates, suboptimal prescribing practices, underutilization of clinical microbiology laboratory services, and the absence of formal antibiotic guidelines. Using data from the Global Point Prevalence Survey of Antimicrobial Use and Resistance, Professor Oduyebo and her team established a decline in inpatient antimicrobial prescribing rates from 80% in 2015 to less than 40% in 2019. She highlighted in another multi-center study conducted in 2015 across 4 Nigerian teaching hospitals, which further showed that only half of prescribed antibiotics were appropriate at the time. In 2019, Professor Oduyebo's team evaluated surgical antimicrobial prophylaxis practice in 18 Nigerian hospitals and found that cephazoline, the recommended first-generation cephalosporin for many clean contaminated procedures, were not prescribed because they were unavailable in Nigeria. Luth subsequently introduced its use, contributing to changes in prophylaxis practices for cesarean section and other surgeries. In 2021, a team developed a global point prevalence survey tool to measure outpatient antimicrobial prescribing patterns. The web-based platform provides standardized data entry, validation, and real-time reporting that is freely accessible to institutions worldwide. Beyond research, Professor Oduyebo has strengthened institutional capacity. Her team has mentored 5 healthcare facilities in Lagos State in establishing antimicrobial stewardship programs. In 2023, Luth qualified for the Global Antimicrobial Stewardship Accreditation Scheme of the British Society for Antimicrobial Chemotherapy, marking a significant milestone for the institution. The Luth and College Antimicrobial Stewardship Committee also led the development of Africa's first antimicrobial Stewardship, massive open online course in collaboration with the University of Dundee and the British Society for Antimicrobial Chemotherapy and Infection Control Africa Network. Professor Oduyebo's work exemplifies the mission of the University of Lagos in advancing knowledge, addressing national challenges, and contributing to global scholarship. And leadership in antimicrobial stewardship strengthens healthcare systems and protects the effectiveness of life-saving medicines. Professor Oyinlola Omoniyi Oduyebo, congratulations on giving an informative, inaugural lecture and immense contribution to improving our society and the world at large. Congratulations to you and your faculty. I thank you all for coming and wish you safe return to your various destinations. I hereby declare this assembly closed.